Welcome, everybody. My name is Liz Toth. I'm Dickinson's Director of Alumni Relations, and I am thrilled to have all of you here today with us and with Professor Helweg-Larsen. Marie Helweg-Larsen is a professor of social psychology and the Glenn and Mary Line Todd Chair in the Social Sciences. She is currently the director of Dickinson's Norwich Science Program in England, but is actually joining us today from Copenhagen. So with that, I would like, as we go through the session today, we are happy to take your questions. Please feel free to put them into the Q&A section or the chat. We will keep an eye on both. And we will have a wonderful discussion. So with that, I will turn it over to our professor. Thank you very much.
Thank you. I hope that you can see my screen, which would be blue with the title. Would you please confirm that?
Yes, we can see it.
Perfect. So I use psychological science to understand why people do what they do, or why smart people make not smart decisions, in short. And I particularly the last 30 years have studied how people think about their risks, where those risk beliefs come from, and what difference it makes. And I study many types of health-related events, smoking, most recently COVID, interpersonal violence in relationships, and a host of other events because I'm interested in understanding the underlying explanations. And of course, smoking is not the same as deciding to not wear a mask, but nonetheless, my research focuses on these underlying ideas to help us get a handle on what's actually going on in people's psychology. So I'm going to use a variety of different examples, most of it from my own research and much of it done with undergraduate students at Dickinson. So here's my outline. So 3 major issues here is why does it actually matter how people assess their risks? And then I've structured 5 reasons around why we're not good at it that all focus on well-established social psychological findings that actually have been studied for decades. So they are the optimistic bias, confirmation bias, affect heuristic, Baserate fallacy, and overconfidence bias, and how those events can actually help us understand specifically what's going on with risk, although the last 4 are actually not particularly studied in the context of risk in and of themselves. They can also explain other events. And then, of course, I know you're all dying to know at the end, not just how we are wrong and confused at times, but what we can do about that. And I have a couple of suggestions, the last of which might surprise you, since the risk research are actually suggesting that sometimes it's perhaps best to dial down the risk estimation. I'd love to have your questions, and you should type those in the Q&A along the way, and I'm going to stop occasionally so that we don't have to wait until the very end to get the questions, because sometimes it's better to get them along the way. All right, so let's first jump into it. So why is it important to understand how people assess their risks? So invariably, almost in any kind of human problem, people do make some attempt at estimating their risk. So this, of course, has become particularly noteworthy in the pandemic because people have discussed extensively and often consider for themselves what is risky and what is not risky, and how that is related to how they should then act. And of course, people try and estimate the risk to themselves and to other people. And we'll see that that also leads to some consistent biases or blind spots. So the point is that psychological science underpins a lot of reactions to the world that we live in, whether it's wearing a bicycle helmet, getting your kid vaccinated or yourself, and COVID, whether you should quit smoking, whether you should take the medication that your doctor is prescribing you. So the problem, not surprisingly, probably guessed this, all of you, is that the problem with thinking that you're not at risk is that it affects your behavior. Because if you don't think you're at risk, why would you wear the mask, or why would you take the medication, or why would you wear the helmet or use the seatbelt? So thinking you're not at risk, whether it's accurate or not, which is a question we will return to, does affect your precautionary behaviors. So there's lots and lots of evidence for this in different domains. So for example, in my own research on smoking, I found that smokers who thought that their personal risk, in this case for lung cancer, although of course smoking causes lots of other problems, but we looked specifically for lung cancer, were much less interested in quitting smoking. We also find, for example, with smoking, that people who are about to undertake smoking cessation program actually come to think that their risk of negative consequences of smoking is greater as they're contemplating a smoking cessation program, and the increased personal risk remains high throughout their smoking cessation program and afterwards if they're successful. But if they fail in their efforts, which unfortunately most smokers do at quitting, then they reduce their risk estimation back to what it was before they began. So basically they said, oh, it's super risky to be a smoker, I really should quit. I'm now going to try and quit, and then I didn't succeed, and now I conclude that it probably wasn't that dangerous anyway. In a study with Dickinson alumnus Larry Harding and I, we examined women who were in a domestic violence shelter in Carlisle and other nearby shelters, and we were interested in whether they thought that being at risk of being battered again by the domestic partner affected whether they were going to end their relationship, and it did. So they did consider the risk, and it did lead them to at least consider ending the relationship if they thought that they were at risk of experiencing battering again. In this study, which is not published yet, also with two Dickinson alums, Sarah DiMuccio and Laurel Peterson, we collected data among US adults, a large representative sample of 1,000 people across the United States. And there we also found that thinking that you were not personally at risk for infection predicted behaviors, important behaviors, such as not wearing a mask, not social distancing, and also less interest in an eventual vaccine. And those certainly anyone would argue are all important steps to take to reduce not just your own risk, but everyone's risk. And thinking you were not at risk made those steps seem less important. So risk assessment is important. What's also important to note is that sometimes people conclude from my research that people are idiots. And I would like to argue that that is not really the conclusion I'm leading you towards. It's more that people are biased, not that they are really in denial. So perhaps wearing rose-colored glasses is a better description of that. So we kind of tweak facts and information in a way that suits our pre-existing beliefs. So for example, in another study I did on smoking, which is also consistent with lots of work, is that smokers knew that smoking was dangerous. When I interviewed in a different study than this one smokers, they said, yeah, I know smoking is not good for you, and it's kind of stupid. But nonetheless, they still thought that their personal risk of having negative outcomes were smaller than they thought the risks were for other smokers, including getting lung cancer. Smokers actually also hold a variety of other optimistic beliefs. They think that they're less at risk than other people because they think that they inhale less deeply. They think they take fewer puffs, and they think they also smoke healthier cigarettes than other people. I'm not quite sure what a healthy cigarette looks like, but that's at least one of the arguments that smokers have when you question them as to why their risk ought to be less than the rest of other smokers. So people then adjust their beliefs to their circumstances, but often inadequately. So let me show you a specific example of that. So in this study, I asked American and Danish smokers. I do a lot of my research cross-culturally with Denmark, and I just asked them on a 7-point scale, what's the likelihood that you're going to get lung cancer? And so let me show you the charts. So at the x-axis, I simply just took all the smokers and I divided them into groups about how much they smoked. So the bottom x-axis is simply did the smokers smoke 10 or fewer cigarettes a day, or 11 to 19, or more than 20. So basically you could say a rough estimate of their risk, right? Because it's dangerous to smoke, but it's much, much more dangerous the more you smoke. And the y-axis is simply just their risk, so a high number is more risk. And again, it was just their personal risk of lung cancer. So what you would expect is a not flat curve, right? So you would expect if the high smokers thought that smoking was put them at increased risk of lung cancer because they smoke more, the line should be not flat, which is what we're seeing here, right? So and remember, we just asked them, what do you think your personal risk is? We didn't say, in light of how many cigarettes you smoke, what's your personal risk? We simply just ask them, what's your personal risk? So you're seeing that there's some adjustment here to the reality of smoking more is definitely leads you to have a greater personal risk of lung cancer. Now in the Danish sample, the line was completely flat. In other words, the Danish participants, which is part of a general pattern in my research of Danes not being particularly concerned about their smoking. And what we see here is that people who smoke more had the same average risk estimates of people who smoke less, which is really not correct. But my point here is that if you look at the actual risk of increasing the amount of cigarette, it's many, 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 many times higher the more you smoke. In other words, we can easily see that Danes perhaps were unrealistic, but so were the American smokers. So the American smokers adjusted somewhat, but definitely inadequately to the reality of smoking more being tremendously much more dangerous to your personal lung cancer risk, whereas the US smokers perhaps thought it was somewhat less dangerous. All right, so let me pause here before I jump into my 5 whys and hear whether you guys have any questions at this point. So far we have talked about why risk matters. And now I'm going to talk about why people are not good at their risk estimation.
We do have a couple of questions. Our first question, any advice on how to use data and research to assess risk and make decisions? For example, in the health field, there is sometimes research that suggests 2 totally different avenues forward, or one report that says that something is good and then another says, well, actually that might not be good, or small scale research that suggests something that is assumed as being helpful might actually be harmful. How might we parse through it all?
Yeah, it's really, I would say the healthcare industry has done a spectacularly poor job in general of communicating what a big, small, large risk is. I was actually pleased to see that the CDC guidelines right now actually had a range of risk behaviors, visiting with other people, and then they had a small, medium, and larger risk set of instructions. And that was pleasing to me because exactly as you said, it's terribly confusing to make your way through the literature. And it's confusing when small studies come out with a lot of media attention that are either just small or contradictory to what we generally know about that, or for lay people, difficult to figure out what the relative risk is of something. So one thing, for example, I often hear from smokers is that they say, well, lots of things are dangerous. I could also be hit by a bus. I'm not sure why it's always a bus, especially in Carlisle. There's really not a lot of buses in Carlisle. But that aside, the point is there's other things that are dangerous, right? Or they think about pollution. But the scale here is just all out of whack because those other behaviors are astronomically less risky than smoking. There's literally nothing you could do that's better for your health than to quit smoking, and all those other things fall aside. So it's complicated, and I wish that pharmaceutical companies and physicians were better at communicating relative risk. So what is it you are actually gaining by taking the hypertension medication specifically? And we'll return to this issue in a second, because I would say that people in general have absolutely no idea what their risks are of various behaviors. And that's in part because you might not know that objectively, but also because people are really just terrible. So to answer the question more directly, I would challenge the researchers speaking about risk, or the physicians speaking about risk, or anyone else to say, how serious is this risk relative to other risks? You want me to take 3 types of medication, which one is getting me the biggest bang for the buck relative to what it gets me? So ask for this kind of information, and unfortunately, physicians often don't know it either. To be fair, there's actually quite a bit of research showing that physicians are not markedly better at understanding or communicating risk than non-physicians.
Thank you. We have one more question before we resume. Have there been any studies about smokers and mask wearing or social distancing during COVID?
So that's a very good question. So a fascinating topic. So smokers definitely have adjusted their behaviors in response to the fact that smoking, it's easy to understand since COVID attacks your lungs, and smokers are more vulnerable, and smokers have reacted as one would expect, like we've all reacted, right? Some smokers have used the quarantine and new risk information as a good reason to quit. Some have not been affected, and some have increased more, and you can all guess the reason, because it's been incredibly stressful, and smokers, of course, feel less stressed when they smoke. So the studies do show that smoking is an increased risk, and smokers have reacted to that in those three predictable ways. No change for the better, change for the worse. All right, so let's go on then. So the first big why, the one I probably spent most of my career studying, is the optimistic bias. And the optimistic bias specifically refers to risk and to the tendency for people to think that they're less at risk than other people. This has been shown in thousands of studies, so I'll just highlight a few. So we looked in another study with alum Hilary Harding. We looked at college students' predictions of whether they would have a happy marriage or avoiding divorce, and they showed the standard optimistic bias. They thought they were less likely than other people to experience a divorce and more likely to have a happy marriage. In my dissertation, I looked at unplanned pregnancy, sexually transmitted diseases, and age and HIV. And again, you see the predicted pattern. Whatever people thought their risk was, it was less than they thought the risk was of other people like them. Interpersonal violence, this was a study we did at Dickinson with college students on violence in dating relationships. They also thought they were less at risk than other people. Lung cancer, we already talked about, and getting infected with COVID in this new study. We also found that whatever the risk was, people thought that they were less at risk than other people. Let me show you, just because it's a little more fun to look at data. So this is alum Laurel Peterson, who was a student, and I were part of a large grant in collaboration with physicians at University of Pennsylvania. And we had hypertension patients in the sample. So let me first just say a few things about the study. So these were all patients who were under physician's care, and despite taking medication for hypertension, actually still had out of control hypertension. In other words, they were in a very dangerous situation, and it was not clear whether they were not taking the medication or whether it wasn't working or what the problem was. But in any case, we had patients who were currently being treated for hypertension, but still had too high blood pressure. And the y-axis here is simply from a scale of 0 to 100, what is your chance of having a heart attack in the next 10 years? So we asked them two types of questions. First, we asked, what do you think the chances of someone who's like you? Your gender, your age, your type of medical condition. And the participants, of course, weren't exactly sure of that. So on a 100-point scale, so this wasn't meant to be a percentage. It was just a 100-point scale, but they guessed around 50%. So they thought, well, people like me, they have a 50% chance. Then we said, well, what's your chance? What's your personal chance? And you won't be surprised here, because you were paying attention earlier about the optimistic bias. And they weren't sure about that either, of course. I don't have the error bars on the graphs, but there was a lot of variability. But they were pretty sure that it was less than that of other people. So the standard optimistic bias. One thing that was interesting about this study is that we actually took their charts, their medical charts, every single patient in this study, and we gathered information from this and entered it into a risk calculator. So the risk calculator actually gives you a percentage from 0 to 100 that estimates each person's actual risk based on factors like age, previous heart attacks, whether they have high blood pressure, which of course these participants did, and so on. So interestingly, which I just wanted to present to you to throw a bit of a wrinkle in, is that people were biased in two different ways. They were biased in that they thought their risk was less than that of other people, but they also had no idea clearly what their actual risk was. So they estimated both their personal risk and someone else's risk as way higher than their actual risk was. Again, going back to the earlier point, that probably physicians have never talked to them about whether the other participants, whether their risk actually was, or just whether taking the hypertensive medication would actually lower their risk. The other thing that's worth mentioning here is that 21% is astronomically high. Having a 21% on average risk of having a heart attack in the next 10 years is exceptionally high, which is also consistent with the point I made earlier, namely that these participants were at high risk for having negative outcomes. So just to round out this particular story is that we had actually originally in the grant, which was a large 5-year grant, intended to run this risk calculator for each individual participant and tell them what their risk actually was in order to convince them to take the medication and take other steps that would reduce their low blood pressure. And we, you will not be surprised to know, decided not to do that because we would actually have told them that their risk was lower than they themselves thought that it was. So in case you wonder about people's actual objective risk in these biases, it is extraordinarily difficult typically to find out what someone's risk actually is on an individual basis. I'm sure you've all tried to do that at some another point for COVID. And it's very difficult because you don't know how to average in all the factors together. So we did know that in this particular study, but that's not necessarily available to most people. All right, so one reason then is optimistic bias. People, even when they don't know the risk, assume that it's less than that of other people. And we've certainly seen that pattern with COVID. So whatever the risk is, my risk is less. All right, so the second reason then is confirmation bias. So this is a bit of a different reason that really has to do with how we find information. So confirmation bias is the tendency to search for, interpret, favor, and recall information in a way that confirms or supports one's beliefs or values. So it's easy to see here that how this would work. So let me give you a simple example. Is that if you are a person, or perhaps someone you know, who thinks that women are worse drivers than men, you might actually be interested in confirming that through your own intuitive observation. So every time you see someone in traffic, you might notice women who seem to be driving poorly. Of course, what you fail to do is notice women who drive well, or you fail to notice men who drive poorly. So your information gathering is fundamentally biased towards supporting your idea because you are eliminating the types of information that would falsify your hypothesis. And so this biased search then leads to a biased interpretation, of course, and you might then feel confident that you are even more right because you have gathered your own informal and biased information to support your incorrect argument. So fact-checking, women are much better drivers than men and have many fewer accidents and death as a result of their driving and fewer speeding tickets as well, which is a huge risk. So you might also be incorrectly gathering the information, of course. So you might think that the poor driver actually is a woman, even though you can't actually really tell because it's hard to tell the gender of somebody's poor car. Or you might interpret someone speeding that you clearly see it being a man as not fitting into the bad driving. Actually, once had a student argue that it was not good evidence that men were worse drivers just because they had more accidents. So we have to talk about data and what that means. So, and of course, not surprisingly, social media amplifies this confirmation bias because we literally in algorithms that are set to us are less exposed to other perspectives. So the confirmation bias is something you can actually deliberately work on if you want to. You basically have to think backwards. So if you want to know why masks are good, you should search for why masks are bad. Or if you want to know why you should have a big party, you should search for why you shouldn't have a big party. So you should seek falsifying rather than confirming evidence. And of course, scientists do that by having hypotheses that can be falsified, although of course, scientists are also biased, but at least we have methods for trying to counter this bias. All right, so the affect heuristic. So now we have optimistic bias, and we have that people are not good at seeking disconfirming information. People also rely a great deal on their emotions in making risk estimates. So a heuristic is just what psychologists call a mental shortcut or rule of thumb. And we are very much influenced by affect or by emotions. And people often interpret, in fact, questions about risk as questions about their worries and fears. So this is called risk as feelings. So when I ask someone about their risk as a researcher, I'm often looking for cognition. In other words, an assessment of their risk that derives from their thoughts, cognitions. But people usually think about these as questions about their worries. So in an ongoing study right now, we interviewed students studying abroad in Copenhagen, US students, what they thought about the risks of studying abroad. And most of them didn't even think about the cognitive part. I did have one student who said, well, I live in a rural area in the US and I've never lived in a city, so I was worried about crime. But then I looked up the crime statistics and saw that they were way lower in Copenhagen than they are in my hometown, and therefore I wasn't worried anymore. So they interpreted and thought about their risks almost exclusively around their fears and worries. And in the data we just collected in March, we saw, which was very much what I anticipated, that the more worried people were about getting COVID, the greater they saw their personal risk. So worry then and fears increase perceived risk, but perceived risk also increases worries and fears. So I wouldn't necessarily say it's wrong to let your emotions guide what you think. It's understandable that if you worry about getting infected, that you would think that your risk was higher for COVID, or that if you think your risk is high, that would worry you. So this is not necessarily irrational. It just, as we'll see in a second, means that the non-emotional talk of experts might not connect well with you. So just one other point about affect or emotions is that everyone we are surrounded with, of course, feed into our worries and fears, and no politician or money raiser or anyone else has ever said, you shouldn't worry about this, but I still want your money, right? Or vote for me. So everyone argues in some other way that the issue that they're fighting for is one that should cause you worry and is a risk. Journalists also rarely have a science background, except for major newspapers or statistical training. And of course, even the New York Times would rather tell you about the one wedding that led to 57 people getting infected, rather than the 10,000 weddings that didn't. So risk information, which is a whole separate risk communication field, is difficult because you can frighten and frustrate the public in ways that's not necessarily leading to your desired outcome. So again, the point is not that you shouldn't be worried, but just be aware that your worries might unduly bias you towards thinking that something is risky, or your lack of worry that something is not risky. All right, so people also not good at numbers. This is probably not a surprise to you, since we are kind of on the long list of how we are wrong. And so psychologists sometimes get on that path. So if people have both statistical information about a prevalence, so cognitive, rational, statistical information, and individual information, we almost all prefer the latter. And this goes to actually making any prediction, even if it doesn't have to do with us. So we just are not really sold by statistical information, and it's easily overwritten by knowing something specific about someone. So we are also enormously guided by our own experiences, which is also not necessarily a bias in all cases, but I'll give you some examples where it might lead you astray. When I lived in Los Angeles, I went to graduate school at UCLA. There are shark attacks in Los Angeles, and there are many surfers, so it's very rare, but it happens. And I was listening to the news when the surfer, they somehow managed to interview him as he was being carried into the ambulance with the shark bite. And they asked him, so will you now quit surfing? And he said, well, of course not. What's the likelihood that I'll be bit by a shark twice? So this particular story shows one pattern that you sometimes see, but which is pretty rare, which is that he felt that he had become exempt. So basically one experience meant that it wouldn't happen again. So humorous as that is, yes, it's unlikely that you would be bit by a shark twice for sure. But it's also not like the shark runs up and swims up to you and goes, oh, well, this guy's taken, I'm not going to bite him again. So probably not accurate. So most people do increase their risk perceptions after experiencing the event. So the easiest thought experiment I can take you through is to think about what happens when you're driving and you see a bad accident. So how much longer after you see that do you feel unsettled, or you think it's really more risky than you think it is, or you feel that your own risk perhaps of getting in a car accident is higher? I mean, maybe 10 seconds, maybe 50 seconds, maybe it even lasts to the end of the drive, and then it goes away, right? But if it was you who had a a serious car accident, your increased risk perception of getting in another car accident could last for weeks, days, weeks, months, years. So there's lots of research on this. Here's just one of my studies that showed that the experience of dating violence made it easier to imagine oneself as a victim in the future. It made you feel less in control. So we often use perceived control as thinking it's not going to happen to us. And of course, it increased worry, which, as you all know, influences risk perceptions. So again, it's not necessarily an error to let your prior experience guide your risk perceptions, but obviously watching another person have an accident doesn't actually objectively influence your own accident picture. So experiences loom large, and that can counter evidence that's more statistically based. So experts are good at reading. You might wonder that. So experts are in fact good at reading and understanding data, especially in their own field. So there's actually research that shows that experts are not better at understanding data in other people's fields. So people who are experts in climate science are not suddenly virology experts, although everyone seems to have become an epidemiologist during the pandemic. So we often ignore experts who really are very good, but not perfect at risk estimation. And there's several obvious answers to that. One is that our society in general has a strong anti-science and anti-expertise trend going on, in which experts are minimized as irrelevant or not important. Experts themselves, like I mentioned earlier with physicians, are not always good at communicating in a clear way. And they often tend to ignore people's fears, which can be particularly frustrating to people. And of course, importantly, experts can speak about trends and patterns, but we want to know what our risk is, right? And an expert, unless they had the type of risk calculator that I just described, wouldn't be able to really help with that. So there are some risk calculators you can look at online, for example, for breast cancer, but mostly it's hard to know what exactly your risk is. So we are convinced by stories and not statistics, and that's probably part of why we ignore experts. All right, so as if we didn't have a long enough list of ways that we are biased, here's our overconfidence bias. Now, I'm sure all of you have met the person who was unduly confident about some mistaken belief. So the definition is that it's the person's subjective confidence in their judgment, which is greater than the objective accuracy of those judgments. Now, this is particularly pronounced for people who are extremely confident or extremely incompetent. So the Dunning-Kruger effect actually isn't about risk at all, but just in general speaks to that it's especially people with low ability who overestimate their ability. So there seems to be blinders on, and the same people who have blinders about thinking that they are right when they're wrong, also the people who are least able to recognize that they are wrong. So with respect to risk estimation, we see overconfidence, particularly among white men who tend to view their risks as lower than other groups, whether women or other racial groups. Although future research on this white male effect actually suggests that it might be a social inequality effect. There was a study in Sweden that showed that there were no gender differences, but there were immigrant versus non-immigrant or native versus non-native Swedes. In other words, it seemed to capture differences in privilege rather than necessarily tied to the status. So it generalized beyond just being a white man. So people of privilege tend to think they have more control over negative outcomes, which is not necessarily entirely wrong, but nevertheless consistent with this bias. All right, so let's put it all together. Well-established heuristics and biases can help us see why we don't estimate our personal risks well. Incorrect on certain information leaves us open to risk minimization and rationalization. That certainly has been the case for COVID, in which we have not and still do not have all the facts about the illness. But honestly, we have known for 50 years exactly the circumstances under which smoking kills, and smokers are still hugely motivated to minimize their risk. People who have strong beliefs like optimistic bias or risk minimizing beliefs they're just hard to modify, and I'm going to give you some suggestions. I actually, at one point, thought I was going to do my dissertation on how to reduce optimistic bias beliefs, and I'm glad I didn't, because subsequent research has shown it to be nearly impossible. Because if people want to think they're less at risk, they're going to find a way to do that. Further, belief perseverance, which is another psychological finding, is that beliefs continue even if the evidence for them is shown to be false. So people do hold on to beliefs and are quite resistant in changing their beliefs, even if you show that the foundation of their beliefs was false. And we're certainly seeing that with coronavirus as well. Early in the pandemic, the Danish government said not just you shouldn't wear masks, but they said you shouldn't wear masks because the evidence is not that convincing. And that has significantly contributed to Danes being more skeptical of mask wearing now, although they follow the rules, because Danes tend to follow the rules, but significant degree of not believing that mask wear, which is exactly what belief perseverance is. So early evidence is hard to adjust. And then, of course, overconfidence can lead naive beliefs to be easily manipulated, just like it's just the flu. So perceived risk affects decisions and behaviors among decision makers. So remember, all these biases I was focusing on us maybe as patients or individual decision makers, but of course they also affect politicians and policymakers and scientists and so on. So this cuts across the board. Let me give you my 3 takes on what to do, and then I will take your questions, because I bet you have questions about what we should do then about this barrage of seeming barriers as to what to do. So my first suggestion is just maybe accept that you're biased and wrong. That might not undo these biases, which seem to serve their own psychological purposes. But at least we can all pause and consider that our reasoning might be flawed, and perhaps we are just looking to support our own beliefs instead of objectively assessing our risks. I know that's kind of disappointing of an answer. So here's something else. So what about just looking for facts? So what we're seeing, at least in part of these ways that we go wrong, is that we're not very good at looking at valid and reliable information. So a risk expert is better than whatever you read on Facebook, obviously. It seems obvious, but nevertheless important, as we are interacting with social media and perhaps don't always carefully check the source. The last suggestion, as I said in the beginning, actually might seem funny coming from a risk researcher, but I would actually suggest that maybe you don't try and estimate your risk necessarily. So 2 different suggestions about how you can approach risk estimation without trying to do this kind of risk calculation that can be so difficult. So there's some research showing that what's actually much the way that people make decisions that influence their subsequent behavior is gist-based risk estimation. And it's exactly what it sounds like, namely that you form a bottom line meaning of a message, and you form a value or broad idea rather than looking at the verbatim details. So the way they did this, some of the studies with children, is that they asked children of various ages. People tend to get better at this with age. So adults, the older they get, do more gist-based estimation. So they asked children of various ages whether it was a good idea to swim with sharks. And the younger children were likely to ask additional questions like, what kind of shark is it? How long do I have to be in the tank? Has the shark just eaten? And other things that could seemingly seem like a good idea, right? They were actually asking pretty detailed questions, verbatim details, right? Facts about the sharks. But the older children gave a different answer. They said, no, that doesn't seem like a good idea. So this is the kind of gist-based risk estimation that an older child could. I don't need to know whether the shark is hungry or not because it seems like a bad idea. So using a different example, so I'm in Copenhagen now, and bike traffic, even during COVID, is very, very, very hectic. And you might wonder whether you should wear a bike helmet when you bike in Copenhagen. So you could try and look at risk estimation. There's not a risk calculator, but you could try to go, well, where am I biking and what time of day, and is it on this busy road, and so on. Or you could have a gist-based estimate, which is wearing a helmet is a good idea. So basically, risk researchers are in some ways fighting against each other with gist-based risk reasons. So smokers, for example, one of the most difficult gist beliefs about smoking that smokers have is that it's worth it. So smokers might say, well, I know it's dangerous, I know it's dumb, I know I smell bad, I probably should stop, but I'm not going to because it's worth it. So that kind of risk gist, you could say, is actually very hard to overcome, right? So you would have to replace it with some other risk or value, such as it'll make my kids happy. All right, so the last one is to not try and go into the details and the weeds of estimating risk, and instead say, vaccines seem like a good idea because they're proven to save lives, and I'd like the COVID vaccine. The other way that you can kind of skip over the confusion aspect and the errors of risk estimation is just do the right thing. So think about the things you already do now. You probably don't ever assess your risk. So every time you brush your teeth, once, twice, 3 times a day, you don't go, well, I am engaging in cavity reducing risk behavior now. No, you just brush your teeth because that's what you're used to. So establishing habits can just completely undo the effort at estimating this. In fact, probably none of you have ever looked up how much toothbrushing reduces your cavity risk, right? Because you just do it. Same thing with your seatbelt. Now, of course, it's also the law, but nevertheless, you wear your seatbelt and it's a habit, and you don't think about whether each seatbelt usage reduces your risk of being injured in an accident, because it's just the right thing to do. So same thing, of course, with COVID. Just wear the mask and don't worry about the complex details, which you're not an expert in, probably, and instead just wear the mask or do the social distancing or wash your hands, and don't get led astray by misinterpretation or aspects of the risk. All right, that's what I got for you guys. Now I'm ready for your questions.
Okay, thank you very much. Our first question: when individuals in an organization know the poor conditions underlying risk are the same influences in action. I'm thinking of Apollo 1, when everyone knew that 100% oxygen atmosphere can result in explosive combustion, but the knowledge wasn't applied. Also, the Challenger incident, engineers had warned that O-negative rings were less effective at close to freezing temperatures, yet the launch proceeded during cold weather.
Yep. And the question is?
I guess the question, when individuals in an organization know poor conditions underlying risk are the same influences in action.
So a great question. And of course, there's an entire field dedicated to having organizations consider risks. And of course, they failed in this case. And there's many, many other examples in which they have failed. And psychological scientists are actually often called in to exactly try to figure out what went wrong, either in the flows of communication or how it was dealt with. So there's some really interesting psychological science related to this point about how people interact in a cockpit to try and counteract the human factors that have led pilots in the cockpit to either not communicate correctly or follow the rules, or not say, as the question suggests, that something was wrong. And that, of course, I know I'm biased, but that's, of course, is ultimately a psychological question.
Our next question: are there any ethical concerns about not telling the high blood pressure subjects their risks were lower than they thought?
Yeah, so that's a good question. We actually talked about that in some length about what we should tell people about their risks. And we actually decided to, so we didn't have the information at the time, so we couldn't have told them because we had to look it up months later and go through all their reviews. But the question still stands: what if we could have been able to tell them that their risks were? Our concerns were actually that that's a conversation that the patients should have with the physicians that were treating them if they felt this information was important to them. And second, that we just simply decided not to go in a risk direction at all. And I was the risk researcher on the grant because people don't understand their risks well. And if we decided not to communicate it and felt that that was, of course, perfectly acceptable because they wouldn't have known that information, whether they'd been in the study or not.
All right. Our next question. In project management, a lot of time is spent on risk mitigation and trying to lower risk from projects because risk is seen as bad. However, sometimes it is more beneficial to projects to accept risk will happen and then putting in place appropriate measures to handle risk when it occurs rather than trying to avoid it altogether.
Yep.
Is there,
of course, go ahead, sorry.
Is there then something in the inherent nature of risk being seen as negative, a negative thing that causes people to downplay or ignore risk rather than accepting risk and how to approach it?
Yeah, a great question. So again, this is outside of my area because you are exactly saying the correct thing, which is that you should never attempt to have zero risk because that's impossible, right? Or at least it's nearly impossible. So there are some circumstances under which there can be zero risk. If you don't have sex, you're not going to have an unplanned pregnancy. If you never leave your house, you probably will not get COVID. If you don't get on a bicycle, you certainly won't be in a bicycle accident. But of course, that's neither practical or desirable. So the way I understand it, but the person asking, I wish I could talk to you, but we're talking one way, we'll have to email. The point nevertheless stands that it would be ridiculous to imagine a world in which anything had zero risk, except for these certain specific circumstances that are driven by behavior that you can choose to not engage in. And I think COVID is a good example of this. So everyone has reopened based on a risk estimation calculus that never includes zero risk. So for example, all the Danish schools are open and they have all the social distancing in the classrooms and they take turns and they wash hands and they test incessantly and everyone is sent home if there's one potential case and so on, but no one is expecting there to be zero cases, right? So what we're trying to do, as those of you who are COVID experts, is that we're trying to get the infection rate to not exceed the R0 value, the how many cases one person gives others, to be more than one. So nobody has ever thought that there should be zero risk, and that certainly is not possible, or like the question answer said, desirable.
Thank you. One more question. With increased polarization in society, where many choose their information sources for confirmation, not information, would the confirmation bias measurements made in 2020 be higher than, say, 2005 across the board?
Great question. So we actually looked at this question in the COVID data set we had, whether conspiracy beliefs. So there's two different aspects of this. So actually having wrong information, it has definitely increased, I believe. It didn't seem to influence people's risk beliefs necessarily, but it did influence their behavior. So the more conspiracy theories they had about COVID infection, the less likely they were to engage in precautionary behaviors, which is a serious concern, right? Even though it didn't affect their risk. So the polarization here is a slightly different question, which is what the person asked, namely, whether we are increasingly due to social media and other spaces seeing a limited version of ourselves. I don't know any data on that off the top of my head, but I would definitely expect that to be true because it's playing into what we already do anyway, which is you type in questions into the Google search engine that would give you answers that support your views, but now we're actually also on social media seeing other views. So one small thing I have actually done, which is small, so I will preface it by that, is I've actually stopped in social media following people who in a very uninformed way, consistent with my own belief, share information. So I actually thought I should get fewer people who agree with me. I've not been as successful as getting more people who disagree with me. So that's a task we can all undertake, right? Try and think about why people think what you don't think. And I hope I've been successful in this talk to suggest that people are actually not stupid. So it might look to us that some people are making stupid decisions, but their rationales are sometimes just misguided because they are weighing things differently than you yourself weigh them. So the question really is, how can we help ourselves and others to make good decisions? And well, lecturing someone or calling them stupid is definitely never that. Instead, ask people what factors have played a role in their decision making.
Well, I think that is the end of our questions. Thank you very much to everyone for joining us. And Professor, anything final you want to make sure the group knows?
Yeah, thank you very much for joining me today. And feel free to read more about my research on my page or shoot me an email. My email address is also on my Dickinson page. And thanks for joining me, and have a great day.
Thank you. Thank you to everyone for joining us. And I hope we will see you again at another program soon. And thank you, Professor, and enjoy the rest of your day. Bye, everyone.